This is Chang from the DeBakey Heart and Vascular Center. I'm presenting today our grand round speaker, Dr. Muhamed Saric from New York Langone Health. He's the director of the Echo Lab at the hospital and associate professor at NYU Medical School. Welcome, Dr. Saric.
Thank you so much. It's an absolute pleasure to be here.
It was a great talk. I really enjoyed it. You started with some slides on history of medicine. What made you interested in history of medicine?
The history of medicine, it's really to provide some flavor that there are real people behind the real discoveries. Often when we hear talks or read books on a particular topic, it's often is dry and it's really presented just as facts. But there are real people, real workers, and real institutions that stayed behind. So it's important to remember these real people who provided us with insights of a different aspect disease. Here we talked about atrial fibrillation, we talked about Eindhoven, who discovered EKG and who was the first to record atrial fibrillation, although he didn't even know that it was the case, and it took a few other people to find out that Thomas Lewis from England. So it's interesting to find out that it's really, we have been recording EKGs for more than 100 years of atrial fibrillation.
I agree a lot, and especially, we need to know our origin is. And the next question will be, you presented a great example of how the multimodality imaging can help with the structural heart intervention. Question to you is, other audience mentioned different approach using different catheter. Do you foresee needs for any randomized trials to prove one approach is better than the other in terms of success? Like mostly we do with medicine, especially in cardiology, that we're big in randomized studies to prove that one approach is better than the other.
It's always good if we have, if we can afford all randomized trials. As you know, these trials are very expensive, but any trial would be beneficial with the outcomes data. You have seen this with the valvular disease, for instance. Up to the advance of percutaneous valve replacements, there was very little outcomes data in valvular heart disease that were at the level of randomized trials. And now we have a whole series of such devices. Also in the left atrial appendage closure. Absolutely. Also we have, with the Watchman, we have randomized trials. And I would like to see randomized trial in every aspect of the medicine if that can be done. With respect to multimodality imaging, I really think all of us, we should be versed in some multimodality imaging, and essentially knowing one procedure and one imaging essentially helps us understand the other. And the more we work collaboratively, the better we are in understanding the anatomy, physiology, as well as the procedural guidance.
I can agree more. I'm personally trained in CT, nuclear cardiology, and echocardiogram. And I always told my fellow that regardless what rotation they go into for cath lab, it's essential to have CT. It's almost like a medical school anatomy. My question for you is, how do you integrate those modalities into the training for the fellows who are looking?
So we try essentially, some fellows opt for multimodality imaging. In the early years, when the fellowship was 3 years, and the third year used to be dedicated for imaging alone. And so we could afford that. Now with the expansion of the fellowship, with the heart failure, LVADs, and all the other clinical requirements, that essentially now move to post-fellowship training for imaging fellowship. And essentially we really try to use echocardiography, 3D CT, MR, to really provide a comprehensive package for training fellows in a structural heart disease. So we ourselves, we are one valve team or one electrophysiology team that we use all these modalities to teach ourselves of fluoroscopy, TE, CT, and we all try to learn from each other and find it absolutely essential for the understanding and the success of procedure, the emphasis on multimodality imaging.
Yeah. Team approach and multidisciplinary approach.
Absolutely. We try to leverage the benefit and the strength of all procedure in each particular aspect of the procedure. Sometimes echo is the most advantageous. It's a real time. It's there. We can see it. But in other aspects, CT, we can look at the valvular disease, the sizing of the valves, the TAVR valves is clearly CT is where it shines. But the guidance, interprocedural guidance of complication of a TAVR procedure is clearly where the echo shines. So we should not be embarrassed and if we are, or territorial about each of other. We actually have to say that these are the advantages and limitations of each of these procedures or imaging, and we have to learn from each other and make it for the benefit of the patient.
Yeah, we used to call that silos approach.
We should not have silos. We should break the silos and create our own, that we are a unified group, but ultimately it's the benefit of the patient that
Correct.
It's the ultimate goal for all of us. And the more we learn from each other, the better we are. I can tell you that since I learned CT, I became a better echocardiographer. And I'm not embarrassed to say that essentially I may not have known as much anatomy as an echocardiographer alone, but now with the CT, I have a much better understanding of TE. The same thing is when I started 2D echo and then moved to 3D echo, knowing 3D echo is just taught me to be a better 2D echocardiographer as well.
I cannot agree with you more. I had the same experience. Maybe I should ask this question first, but how do you first get interested into, from being a person sitting in the echo lab, reading 50 echoes a day, to move to a completely different environment, which is the interventional suites or OR?
It's absolutely, I mean, first, the field of cardiology is moving toward the percutaneous interventions. The entire field, that it's the biggest thing that happened in our lives. I think to have a percutaneous, let's say, aortic valve replacement, and 90 minutes later the patient gets up and walks, in just simply a miracle, compared to open heart surgery. Somebody is sternotomy and takes weeks for the wound to heal. It was just simply a miracle, and the entire field is moving, and we as an imagers can truly provide the guidance and success of these procedures. Many of these procedures, for instance, the mitral valve space, would not be possible without the guidance by the imaging. The mitral valve clip, percutaneous mitral valve replacement, without the 3D imaging guidance would not be successful, would not have been even imagined in many respects. So this is truly, and then once you start doing and you're part of the valve team, you see that people are doing CT, and you see start advantaging of doing a CT, and you say, wow, maybe I should try that and I should really learn about that. But the same thing applies for interventionalists. They learn from us. Echo, they really, in the beginning, they were sort of squeamish. Is this really needed? And then there cannot be a procedure. Where is the echocardiographer? Why we are not having so this is an advantage to all of us. We have learned, and we truly became a team, from interventionalist to CT to MRI to echocardiographer. And I think we are living in a better world than before.
So really the concept of continued learning and education.
Absolutely.
Last question will be, do you foresee this as part of the cardiology specialist as a role for the imagers, or you could foresee that actually the interventionalist taking up the additional training role and to be the one doing everything, so?
I would respect this is definitely in the interventional imaging, whether interventional echocardiography or interventional CT is definitely becoming a specialty in of itself. And it requires familiarity not only with the imaging, but also familiarity with the operating suite, what cardiac catheterization and EP lab, which is a separate environment. So there, from the imaging perspective, definitely that's going to be a separate. Whether any of the interventionalists will take upon themselves to do both the interventions and imaging is possible, depend how complex the procedure is. But for some, it's just you cannot be simultaneously in two places doing two different things. We have to see the same with the anesthesiologist. We have in many places, you can have a guidance by anesthesiologists, both the anesthesia and the imaging. But in our experience, we have anesthesiologists doing what they're doing the best, which is providing anesthesia, and we have imaging what they're doing the best. And again, in a collaborative way, we learn from each other, and it's, I assume that there is, and I predict that it's going to be a long way for us to enjoy this field of interventional imaging.
Great. So, well, have a good trip to China, I understand. So would you be monitoring the echo lab and cath lab too?
Absolutely, everything is remote access. Everybody has remote access, and the medicine is now 24/7.
24/7.
Absolutely. So thank you so much for the
It's a
invitation.
pleasure.
Absolute
Thank you for
pleasure.
coming to visit us.
Absolutely. Thank you so much.